just realised that whole time I was speaking I was on mute. So hello everyone, thanks for joining. Sorry for being a little bit late, I was just a bit late getting back from work. I'm just uploading the slides as we speak and we'll get started soon, but I'll give people a bit more time to log in. So yeah, thanks for joining again. So yeah, thanks again for joining. I can see 1 or 2 more people joining. Looks like it's not such a big session today, but that's okay. Hopefully you guys will benefit from it as well. And I suppose if you know anyone who was interested in coming but just couldn't make it today, then we'll obviously upload the slides and the recording. So just bear with me just while these slides are loading, but yeah, we'll get started very shortly. Yes, I know, Ria. It's just that I don't want to get to the point where we reach the limit of the slide, if that makes sense, because the first two are just some quick intro ones. So I'll just wait for just another minute or so, just for like 1 or 2 more slides to load, and we can probably get cracking. Okay, I might give it a go anyway. Well, apologies if we end up having to wait for some slides to load, but it should load as we speak. So I'll start presenting now. Okie doke. So yes, so today the topic is sexual health. So I'm Vicky, a doctor at Eastbourne Hospital, and I'm basically here to just teach everything. Well, not everything. Some of the main bits that I thought were quite useful to cover under sexual health for finals or for whatever stage you're at, really. It's quite a, I think, high yield topic, and also I think tends to be some of the more straightforward questions in exams. So I think really good to have this topic nailed down. So just a quick intro about who we are. So the overall organisation is called MedTech Teaching, and the final series is part of the sort of Thursday 15 series. We roughly stick to about 10 to 15 minutes of MCQs, but to be honest, in this session, actually what I'm going to do is we'll do the MCQ, then we'll go straight into the answer, and then so on and so on. I've got about 8 MCQs, so hopefully it shouldn't take too long. And then I'll go over some of the explanations for the answers as we go along as well. And yeah, so join in on Thursdays for more topics. We have some on Tuesday as well coming up. We're kind of nearing the end of the series, so by like mid-June we'll probably finish. Then also you'll probably have all finished your exams as well by then, so just in time. So in terms of what we're going to cover here, the actual MLA section for sexual health is not a huge section, but to be honest, actually I think a lot of it overlaps with the gynae stuff as well, and the infectious diseases part, but I'm just sort of mainly focusing on the sexual health element of that, but there is definitely overlap. So today I'm mainly going to cover on sort of vaginal and urethral discharge differentials, investigations and management, a little bit of postcoital bleeding, and some emergency contraception and postpartum contraception stuff. So all very high yield, useful information to know for your exams. So let's get straight to it. So if you want to grab a pen and paper or just write on your phone, and I'll give you about a minute to read the question and write down your answer, and then I'll ask you for what you put down first before I let you know what the answer is, okay? So starting off with question 1. Minute starts now. Okie doke, that's been about a minute. So does everyone want to put what they think is the answer in the chat? Any ideas? So this question was actually based on, in fact, all these questions I've really tried to base on what came up in my exams. Yes, I wish I was organised enough to have made polls before this, so I'm really sorry. I think it'll probably distract me trying to make a poll right now. But if no one wants to pop it in the chat, that's fine. We'll just go straight. Oh, gosh, Ria, very helpful. I mean, yeah, feel free to, but equally it's fine, no problem. I will, anyway, just move on to the answers for this one then. So the answer is the first void urine sample. So I suppose it's just this. Oh, yes, thank you. Okay, if people want to, I mean, you already know the answer. So the reason why I put this question in is because I think it's just very important to have a good handle on what tests to do basically for different presentations. And actually in this history here, it's really, really difficult to tell what actually is going on here without some further, I think, investigation results, like some microscopy or something, because it, you know, could be chlamydia, could be gonorrhea, could be all sorts of different things. But actually, I suppose single most useful test in this case would be the first void urine sample out of all of these. You would still do some of these as well as the urine sample. Not saying the others are wrong, but yeah, out of all these options here, that would be the one you'd prioritize in order to help diagnose the cause of discharge. And obviously a swab would still be useful, and that would obviously be more if you're testing for like gonorrhea and other bits. So yeah, and then so this is what I had in my notes as well. So I suppose if you try and make a summary table yourself for when you do certain tests for different types of presentations. So I suppose the standard STI screening will test for chlamydia and gonorrhea, and that you will get from a first of all urine sample, as in the case in this question here, and they send that off for NAT testing. Or if it's a woman, you would send a vulvovaginal swab, and then you can also do HIV and syphilis serology. Although in this case, I think the presentation that he had was less likely to be those things, but you would still do all the other bits and bobs as well. And then depending on other bits of the demographic history, you're going to do further testing. So in Men Have Sex with Men, you would do the 3-site testing. So in addition to the urine, the rectum and the pharynx. And then you can also do hepatitis B and C serology screening. And then there's a whole bunch of other different types of microscopy or viral PCR tests that you can do when you're thinking of more specific infections that you want to test for. So you just need to have a bit more history to sort of guide you as to why you're doing those tests. For something like trichomonas, for example, you wouldn't typically screen for that unless you had a suspicion of it. But yeah, most of the testing will be for chlamydia and gonorrhea in the standard STI testing. Okie doke, so moving on to the second question. So yeah, maybe I'll have a go then at making the poll, if that works. I'll give you a minute whilst you're thinking of the answer here. Very kind of you, Ria. Don't worry, I think actually I can probably do them whilst you guys are thinking of the question answer. So don't worry. Thank you, though. Okie dokes. I think that's been about a minute there, so I will. Oh, I've queued something, but for some reason it's not coming up. Let me see. Okay, I think I've done it. Okie dokes. Pop your answers in. Anyone else want to answer? I think I've got 1 at the moment. Okay, we've got 2. Any more for any more? Okay, we're getting the trend here. So yeah, well done. The right diagnosis here. Oh, we had a late entrant there with E. That's okay. So I suppose let's go through this question then. So this is a 27-year-old female, 5-day history of vaginal discharge. That could be so many different things. So I suppose I was trying to be a bit leading here with some of the clues here, but they have to give you something in the exams as well. So an offensive smell, no pain or itchiness, has a new sexual partner, but sort of to deter you from more of the STI route, she's been using condoms. And on speculum examination, you get this description of a thin grey watery discharge, and the pH as well as the clue. So that's 5.0, sorry. And I think, so I've put a lot of images actually in my questions because that is how they tend to ask a lot of the sexual health questions. I remember in my exam, there was, lots of images actually in the gynae sexual health section. So I think definitely something to include in your revision is, looking at how these infections look under the microscope. So yes, if you'd revised this already, you would know that yes, so that image there shows what we call clue cells. And I've got some slides later on to show you the difference between what normal vaginal flora looks like compared to when someone is experiencing bacterial vaginosis. So yes, well done to those who answered, thank you. And I suppose just before we go into the specifics of bacterial vaginosis, it's good to just make sure you have a good framework in mind of thinking of differentials, because in this case, obviously, there was a lot of clues there to try and get you to think of BV, but always remember to sort of have a broad range of differentials in your mind, and different clues and different aspects of the history are going to just lead you down certain different routes. But yeah, just remember there's infective and non-infective causes, and then within the infective causes, there's non-STI, which is what BV is, but still an infection. There is STI, sort of more in the vaginal area, so that's like trichomonas, and then more endocervical, urethral is chlamydia and gonorrhea. So just bear that in mind. So just going to the specifics of BV. So it's, like I said, a non-sexually transmitted infection of the lower genital tract. And the reason why it happens is because if there's a disturbance basically to the normal flora, it leads to a decreased number of the lactobacilli. And they're actually the type of organisms that keep the bacteria pH sort of less than 4.5. But when the population of lactobacilli is reduced, it means that other types of bacteria are able to grow, other organisms, and then the pH therefore increases as well. So commonly you can find things like, I'm really bad at pronouncing these, Gardnerella, anaerobes, and mycoplasmas as well. They tend to be quite common in BV. Yes, so clinical features wise, this is important. So like I was saying, you might not get something as obvious as like a fishy smell, but they might just say, offensive smell. Usually is not associated with itching or irritation, and the description of the discharge is usually a thin, watery, grey vaginal discharge. And some of those risk factors here just make you more likely to get BV. So new sexual partner, use of the IUD, presence of an STI, use of, scented soaps, recent antibiotic use, and smoking are some. And in terms of the investigations you're going to do, so you're going to do a high vaginal smear, and you're going to check under the microscope what you can see. So you'll be able to see clue cells. I've got a slide just coming up just to accentuate this point. You're going to see a reduced number of lactobacilli and an absence of pus cells. So there's something called the Amsel criteria here. Basically, if you remember all these key features here, you can be pretty certain that you've got BV, especially in an MCQ. I suppose it also could come up in an OSCE as well if they present, if it's part of an examination as well. Here's a slide just to show the difference between the normal flora is on your left of the screen. So you can see here, there's normal squamous epithelial cells, lots of lactobacilli around. I think that's the right thing, And then in the next one to the right, you can see that there are clue cells present. So there's a distinct lack of lactobacilli, and you can see that actually there's a lot of these like clue cells basically around with all the so basically no lactobacilli, and then the clue cells are present there as well. That's basically going to help you diagnose BV. And in terms of management, so most commonly you take metronidazole. This can be taken orally or as a gel, and just basically provide some advice about not using certain products like scented shower gels, and you may consider removing IUD if it is contributing to that. It tends to actually reoccur quite a few times, but hopefully that treatment should treat it, and sometimes you may not even need treatment for it. It will just sort of resolve on its own if it's asymptomatic. Okie doke, so moving on to the next question. So I'll give you a minute to have a think about this. So I think that's your minute up. So let me just pop the poll up. So what did everyone put for this? Any other responses? Give you another few seconds. No. Oh, we've got a little bit of a split here, and I wonder actually because there may be some sort of mixed information out there. But yes, so let's go through this question there. So the answer is ceftriaxone, and so I haven't actually given you much information in this stem, apart from maybe the green vaginal discharge makes you think less likely to be something like chlamydia, but you never know. And actually the main thing I was trying to get you to focus on in this question was looking at that slide, because I'm pretty sure this exact image came up in my exam. So just make sure to have all these sort of STIs and non-STI infections memorized in your head, what they look like on the slide. So we'll go through. This slide here shows the classic gram-negative, like coffee bean shaped, diplococci organisms there. So indicative of Neisseria gonorrhea, and I've got a labeled slide a bit further on as well, so you can just look at it in a bit more detail. And so the treatment for gonorrhea is 1 gram of IM ceftriaxone. So metronidazole, as we just studied there, would be used to treat bacterial vaginosis. Ciprofloxacin used to be the treatment of choice for gonorrhea, but I think as there's been increasing resistance to it, ceftriaxone is recommended. So you can look at these guidelines. There's an organisation called BASH, and I've got I'll have the link at the end. And so just have a look in there, but I think it's ceftriaxone rather than ciprofloxacin. Nitro is for lower UTIs, as you know, and benzyl penicillin used to treat syphilis. So that's how you narrow it down. So just a bit more detail about gonorrhea. So it is a sexually transmitted infection caused by the gram-negative bacteria Neisseria gonorrhea. It's one of the most common bacterial STIs, more common in people under the age of 25 and in men who have sex with men. And it's transmitted through unprotected vaginal, oral, anal sex, and can also be transmitted vertically from mother to child. Like I said, some of those risk factors there include the age range and living in high density urban areas, previous infection with gonorrhea. Sometimes it can lay dormant there for a while, or you just may not have symptoms from it, and having multiple sexual partners as well. So in females, the typical symptoms are sort of increased vaginal discharge. It can be a range of appearances. So sometimes I think just making diagnosis based on the appearance can be quite tricky, and that's why I think they have to give you some other piece of information to help you make that diagnosis, which is why I gave you that microscopy slide there. So yeah, dysuria, dyspareunia, lower abdominal pain, maybe some postcoital bleeding or intermenstrual bleeding, sorry. And in terms of what you're actually going to see, so you're going to see discharge. It can be, like I said, a range of different, colours, and yeah, and you might get some pelvic tenderness as well if it's gone to the stage of where it's maybe causing pelvic inflammatory disease as well. And in males, similar. You're just going to get, obviously discharge coming from the urethra instead. You will also get symptoms of dysuria. You may get tenderness around the epididymis, and then if you have a rectal infection as well, you may not actually know about this. And to be honest, in both males, females as well, you may not, just may not have symptoms. But otherwise, you may also get discharge from the anus and anal pain and discomfort. So yeah, this is the slide I was talking about, which just has a bit more labels basically on it to just tell you what we're looking at here in terms of the slide. So yeah, you can see the diplococci labeled there. And yeah, so that just helps you basically diagnose this from the slide. So in terms of how you're actually going to test for it, so sort of similar to what we were saying in the first question there. So females, endocervical vaginal swab, and that you can do your NAT testing, and you're also going to take another swab for microscopy and culture. For males, it's the first pass urine. Then you're also going to take a urethral meatal swab for microscopy and culture, and if needs be as well, the throat, rectum, or even eye, if indicated. In terms of management, like I said, so it's intramuscular ceftriaxone 1 gram. You should also be screening for other STIs, especially chlamydia. So that's why the sort of STI testing that we're talking about just covers both of them, because they're so interlinked. You could have both. It's really hard to tell the difference unless you physically sometimes see the slide, and even then something could be coexisting. And also you should encourage previous sexual partners to basically to get in touch with them and advise them to be screened, or sexual health clinics as well offer the service to try and maybe keep certain people anonymous as well, and it's called contact tracing as well. And then after treatment, you should do a test of cure at least 14 days after completing the treatment. So, and actually that reminds me of another point as well. So you may actually not test positive for gonorrhea if the sexual encounter happened less than 2 weeks ago. So sometimes, you're going to have to wait a little bit longer for it to test positive. So you may still actually have gonorrhea, but it just won't come up on the test as well. And just important to remember the complications. So pelvic inflammatory disease is one of those if it's left sort of untreated. So that's why even if you're asymptomatic for a while and you're having different sexual partners, they may just offer you screening anyway, even if you're not getting symptoms. Epididymoitis in men, prostatitis, and it could even sort of spread systemically as well, and lead to things like arthritis reaction. So that's actually another good point to know about. They could link it in that way as well, with sort of reactive arthritis from gonorrhea. Okay, moving on to the next question. I'm really sorry for some of these questions. I couldn't think of a fifth option to put down for you. So some of these are only 4 option questions. Very sorry. But have a go at this next question here. I will make the poll as you have a think. You have a minute. So, right, let me get the poll up. Actually, reading this question back again, I don't know if it may be a bit mean to miss or make you make that leap without maybe more information, but I'm hoping you'll have got the gist of this question. So yeah, the poll is up. Have a go at what you think the answer is. Okie dokes, you've got 3 responses so far, bit of a split. Okay. So first of all, I suppose let's go through what we actually think the condition is. So that will help us with knowing what to treat. So yeah, so well done for those who picked D. And I see why we have someone who may have picked B as well. So the key bits of this question are, so she's pregnant, so that's important to know about. And she's got vulval itchiness, vaginal discharge, could be a lot of different things. The discharge is known to be thick and white. So, and then the rest of this stem, I was just basically trying to get at that this is likely not a STI infection, if that makes sense. Although actually it could, you know, who knows? You never know. Maybe stuff in the story might not be completely true, but I think maybe then in the exam they might give you something like a pH as well to help you diagnose this, or maybe another slide. But I figured I just wanted to see if you guys made that leap. And based on the options here, you can see that there's not much else it could be apart from Candida. So the reason why it's not B is because oral fluconazole is not used in pregnancy. So you'd use the pessary if they're pregnant. If they weren't pregnant, you could use both. But yeah, because this lady's pregnant, that's why B is not the right answer. But I see where you were thinking there. And the rest of the answers, so A was the treatment for herpes, and C is the treatment for trichomonas, so an STI infection, which would cause discharge. What are the implications of fluconazole in pregnancy? Yes, I see your question there. I actually don't know off the top of my head, I'll be honest, but just having done some research on these in this area for these slides, and obviously my own revision in the past, I have it very clearly written to not use oral fluconazole. And it's also, very clear in the BNF as well not to use that. But I'm sure there is an actual specific reason why. But just remember that fact. Let me see if... Yeah, exactly. Even knowing it, exactly. So now you'll know, don't give oral fluconazole in pregnant ladies. So yeah, just so you... I think as well, it's very useful when you're revising this topic. Just make just a big table with all your key differential findings and what's going to help you differentiate between all of them. So this one only has BV, Candida, and trichomoniasis. God, I'm so bad at pronouncing these. But yeah, basically it's just going to help you differentiate between all of them. So you can see clearly between BV and the other two, something like itchiness, not having an itch is going to help you differentiate that. The pH, and then I think also the risk factors behind the history as well are going to help you differentiate between them all. And I'm not going to go into too much detail about Candida actually, because I'll be honest, I was struggling a bit for time for making all these slides, but I just wanted to focus on the main bits of this question here. So this is definitely where they could trip you up, if they say that she's pregnant and you don't notice that from the question. So the main thing is, treat with a pessary, don't give oral antifungals. You can treat with topical antifungals for vulval symptoms, but always bear in mind if that there could be an STI going on as well. Don't just simply take the history at face value. And yes. Okie dokes. Moving on to the next question. So have a minute to think. Hoping you're going to get this one as well based on the picture. Okie dokes, that's been about a minute there, so I'll start the poll, have a go. Okay, I'm glad it seems like the picture clue is working. Fab. So yeah, well done to those who answered correctly there. You are right. It is trichomoniasis. I'm so sorry if I've been pronouncing it incorrectly. Anyway, so yeah, you can see here, so key bits of the history are, so vaginal discharge, could be a lot of different things. Postcoital bleeding, itchiness as well. So I suppose you're starting to maybe rule out things like BV. And yes, and obviously the speculum examination is going to be what really helps you diagnose this in this case. So this is what we call like a strawberry cervix. If you think really hard, you can see, I suppose it kind of looks like a strawberry there, but I think the main thing is just these little sort of red dots around there. Yeah, sorry for ruining that fruit for you guys. So in a little bit more detail about this, so it's an STI caused by the Trichomonas vaginalis, and it can be asymptomatic in sort of up to 50% of cases. Key things to remember are, so it can cause discharge, typically described as frothy, which I suppose differentiates it from other STIs, but again, really tricky to know just from the description of the discharge. And something that, will just help you diagnose unequivocally would be something like a strawberry cervix on the speculum examination. And yes, you're going to get other findings here as well. So itchiness, discomfort, and in males, dysuria as well. And in males, similar, discharge, irritation, dysuria, and balanitis as well. In terms of testing, it's not part of the STI screening that I was talking about at the beginning, where you test for gonorrhea and chlamydia as a sort of standard. You sort of have to suspect it a bit more. So I suppose that's where having things like the wet mount microscopy, when you're in a sexual health clinic, you can literally get a bit of the discharge, pop it on a slide, have a look, and that maybe helps you think, okay, whether you need to actually add on a test for trichomoniasis. And for females, using point of care testing using a posterior vaginal fornix swab is becoming increasingly popular. Or you can do the vulvovaginal swab or use a first pass urine sample in men. You just need to specify that you want to also test for trichomoniasis as well as the gonorrhea and chlamydia. And you can also culture it as well. In terms of treatment, we're going to use metronidazole, 400 to 500 milligrams twice daily, or you can give it as a single dose. And you should avoid alcohol during the first 72 hours of treatment. You should undergo full sexual health screen, so don't just go tunnel vision. Contact tracing, partner notification, and a test of cure is not actually routinely required in this case. Okie dokes. Moving on to the next question. So have a go, start the minute timer. Okay, poll is up, so have a go. Tell me what you think the answer is. Any takers? Okay, we've got a few responses there. Anyone think any different? Oh, thanks, Ria. That's very helpful. Yeah, I remember seeing that in the BNF and not really having anything specific, but yeah, just a good fact to remember. Okay, so sorry, back to this question here. So well done to those who answered D. You are correct. So yeah, this is another thing that I'm pretty sure came up in my exam, but the image was a lot blurrier in my exam. So this is a nice high definition picture for you guys. And again, why I put this question in the session, because yeah, they like to use their images in these in this area basically when they're asking MCQs. So let's just go through the question here. So 26-year-old female, I'm so sorry, I feel like I didn't delete the first bit there. Anyway, sorry, 26-year-old female presents to you complaining of bleeding after sex. She's just started using the combined pill. She has no other bleeding in any points of her menstrual cycle. She had the same sexual partner for the past 2 years, so basically just trying to steer you away from sort of the STI route. She's also had a smear test, did not test positive for HPV, so she wouldn't go further in the screening anyway, so very, very low risk of cervical cancer. And yeah, this is what you see on examinations. You can't see really any polyps there. And yeah, there's no discharge, nothing really to make you suspect an infection. I suppose endometriosis, you never know, could always be up there on your differentials, but I think seeing this image here is going to make you think that this is more of an ectropion, because that is exactly what it looks like on the speculum examination there. So going into a bit more detail about what a cervical ectropion is. So basically it occurs when, the endocervix, it basically inverts. So you were going to see tissue that you wouldn't typically see in that area. So things like the columnar epithelium in the endocervical canal, you're going to see that appear where the ectocervix is. And in terms of who you're going to see this most commonly in, sort of adolescence, in pregnancy, and women taking the estrogen-containing contraceptives. The reason why it might result in postcoital bleeding is because there are lots of fine blood vessels present within the epithelial endocervical canal type cells, and that can be disrupted during intercourse. So that's why you see that relationship between this type of bleeding and the ectropion. So here's it again, just to get that image in your head. So risk factors, like I said, COCP, pregnancy, adolescence, and generally happens in menstruating age. It's uncommon to find it in postmenopausal women. So this is kind of in sort of gynae territory here as well, when you're thinking of differentials of vaginal bleeding in general, the differentials you're going to have for a premenopausal woman is very different to what you're going to have for a postmenopausal woman. So just always bear that in mind. Age is very important with these types of questions. In terms of clinical features, may not get any bleeding at all, but most commonly it appears as postcoital bleeding. And then in terms of other differentials to consider, so obviously you do need to consider things like cervical cancer, and that can occur obviously in younger women, premenopausal women, but that's why I gave you that history of the smear test being clear. There weren't any issues there. Also can occur in infections and pregnancy as well. In terms of investigating it, it can be diagnosed clinically, so you often don't need to do any other tests. In fact, I've seen this diagnosed myself in clinic as well without really doing any other tests apart from just getting the history and having a look with the speculum. But obviously, if you are suspicious of other things, you can do pregnancy tests, triple swab as well. And if there's any obvious lesion there, you can refer for a biopsy as well. In terms of treatment, normally doesn't really require treatment. If it's associated with the pill, the combined oral contraceptive pill, you could stop it, find an alternative contraception that might solve issues. And if the symptoms still aren't resolved, you can consider ablation as well of that area. All right, moving on to the next question. So I'll give you another minute to have a think. Sorry, I just realised I was on mute. I've just done a little forward and back. Has it moved for you still, or can you see the next question? Unfortunately not. Okie dokes. You can't too. That's weird. Can you see me moving the slides now? No. So is it stuck on a slide? Let's see if I can. This hasn't happened before. We're stuck on the cervical ectropion slide. Oh, what a shame. All right. Let me see if I can. Okay. Present now. Yeah. Okay. How has that worked? Bro. Perfect. Okie dokes. Right. Let's start that minute again. So here we go. Have a think. Okay, that's been about a minute. Let me get the poll up for this. 2 ticks. Right, give it a go. Lovely. Hopefully made it not too difficult to figure out. But yeah, basically, I think this is a very useful topic to have a good handle on. They can definitely throw in a few more curveballs as well with this. I wouldn't spend too much time in an exam trying to sort of calculate the exact day of ovulation and get too caught up in it all. But hopefully they should give you a nice enough figure for you to be able to just work it out simply in your head. So yeah, so well done. I think most of you've put the right answer there. So well done. So yeah, the copper intrauterine device. So let's go through this question. So we've got a 20-year-old female. She presents to clinic after an episode of unprotected sexual intercourse. She wants to know about her emergency contraception options. You know that she has a 28-day cycle. She's currently on day 17, and the unprotected episode happened 6 days ago. So I suppose already knowing that it's 6 days ago, that already rules out a lot of options here. So the Ella1 and Livanel, that is already outside of their window, regardless of what point of ovulation we're at the moment. So actually, to be honest, it kind of leaves really only one option there. The COCP and Mirena intrauterine devices aren't really used as emergency contraception. So you basically have A, C, or D as your options, and yeah, so you've chosen correct there, so well done. Let's go through a bit more information about emergency contraception. So this question requires you to just have an understanding of when certain emergency contraceptions are effective. In this case, I suppose it doesn't really matter too much about knowing the day of ovulation in a way, because you already knew that levonorgestrel and ulipristal aren't going to be effective 6 days after the unprotected sex anyway. So yeah, but sometimes they might make it a bit trickier and maybe put it where it's 72 hours or less than 72 hours, and you might have more options there, and you may need to use when the ovulation day is to help you know which one's the most appropriate. Because as you can see here, levonorgestrel and ulipristal are most effective right before the LH hormone surge, which happens during ovulation. And so if you know that ovulation's already taken place, even if it's within the 72 hours or less, both those options may not be effective anyway, and that's reflected in the guidelines, which I'll show you in a sec. And you can see that intrauterine device is still effective past the ovulation point for a few days. So it's basically very useful to know the timing of ovulation. So just try and have a think about that in these types of questions. In terms of the mechanisms here, so the copper device, this helps you figure out why you would suggest certain things. So the copper device doesn't prevent ovulation, which is why I suppose it's useful for even after ovulation has taken place. It prevents fertilization and can prevent implantation. The levonorgestrel and ulipristal are only effective, the levonorgestrel only just before the LH surge, and the ulipristal can be effective up until the LH surge, but afterwards it's going to be less effective. And both of them don't prevent fertilization. It's mainly the preventing the ovulation, which is why the guidance is the way it is. So I think if you want to know a bit more about this, it's useful to have a look at the guidelines. I have the name of the organisation at the end. I just can't remember off the top of my head. It's one of these national organisations that forms these sorts of guidelines. So this one here is about the algorithm for making decisions about emergency contraceptions. So you can see here, just by knowing whether it's been less than 122 hours. If you say yes to that, you have basically a few more options. So yeah, basically this is something useful to just have in your mind. I realize it's a bit overwhelming to go through everything at the moment, but just have a look at this sort of guidelines, maybe take a screenshot, and I'll let you know where I actually got this from. But having a good idea of how to make these decisions is helpful. And then in terms of knowing whether to use ulipristal or levonorgestrel, if you're sort of before that ovulation window or just within that ovulation window, so knowing whether the unprotected sex happened less than 96 hours ago. If that is yes, then you need to figure out, has it taken place before ovulation? And that's basically just going to help you figure out which one's most useful there. And I suppose important considerations to have in mind are things like BMI. So they could throw you on that as well. They could maybe put a few different doses of levonorgestrel there. So if someone is BMI is over 26 or weighs over 70, consider a double dose, which is 3 milligrams there. Or if taking an enzyme inducer, so particularly I can imagine them putting in that someone's got epilepsy and taking certain medications that there are enzyme inducers, and that's going to impact the effectiveness, especially for a ulipristal acetate. So that's where you need to just bear in mind. I realize it is quite a lot to this topic, but I think if you just break it down into when has ovulation happened, how long ago did the unprotected sex happen, and just a few more demographic characteristics like weight, do they take an enzyme inducer, and that will just basically help you figure out which one is most effective. So yeah, just have a little look at that in your own time. And here's just a bit more of a simplified version here. So the copper intrauterine device can be used within 5 days, 120 hours, or within the 5 days after the earliest estimate date of ovulation. So that's why in that case, even if it had been 6 days, it was still just after, within the 5 days after ovulation. Levonorgestrel, licensed for use within 72 hours, and ulipristal, licensed for use within 120 hours as well. There we go. All right. Hope I didn't frazzle your brains too much with all that information, but just have a revise in your own time, because it is quite a common topic that comes up. Okay, moving on to our last question. Let me know as well at any point. I kept meaning to ask if you have any questions, basically, so just pop them in the chat if you do, if what I said hasn't made sense, was confused even more, but hopefully that's been useful. So yeah, moving on to our last question then. So question 8, I'll pop a poll on whilst you guys have a think. So I'll start the minute timer. Okay, so that's been about a minute. I'll get the poll going. So yeah, have a think. Okay, so we've got 2 answers for C. Oh, we've got a contender for B. So the answer is C. So yeah, well done for those who answered C. And I can see why you may be thinking B as well, but let's just go through the question again. So we've got a 29-year-old woman, and she presents to a GP 5 days after the cesarean section. So that's the important point here for why that's something like an intrauterine device is not not advised in this case, because you can have an intrauterine device inserted as contraception after pregnancy if it's done within the 48 hours after birth, vaginal birth or a cesarean section. But as it's been more than 48 hours, you're going to have to wait a bit longer for that to be an option again. The progesterone only pill is absolutely fine to start at any point. Technically, if she had unprotected sex up until 21 days, it'd be unlikely that a pregnancy would happen from that. So she doesn't necessarily need to start it now within 5 days, but it's best if she does, actually, because it means that you don't have to wait. After if you, let's say, start the progesterone pill, you have to wait a few days for it to be effective. Whereas if you start it before the 21 days, it'll be effective right from 21 days onwards, if that makes sense. Things like estrogen containing contraception forms aren't recommended this early on as well to start. So if she wants to start it now, which is the indication I'm getting from this, the progesterone pill is pretty much the only option here. And the D is just wrong. You can have different forms of contraception while breastfeeding. You can obviously do lactational amenorrhea as well. That's something, if you don't want to use any form of contraception and want to just go more natural, that's absolutely fine. But you do have to meet you have to be meeting certain criteria, I think, for that to work. It's still definitely an option, but it's not that. So it's the option D is wrong. You can't just say you don't. There's no options at all. So that's why it's C. I'll get to your question in a second, Ria. So I'll just go through the bits here. So when should contraception be started? So like I said, should be initiated by 21 days after childbirth. But again, this depends what the option they want, if they want contraception at all, and if they'll need to use sort of barrier methods if the contraception started 21 days or more after childbirth. So I made a little table here about the different options here. So the IUD can be inserted immediately after birth within 48 hours. After 48 hours, you need to delay that insertion until 28 days after childbirth. Progesterone, anything progesterone containing, so that includes the implants or the pill, that's fine anytime after childbirth. That can be including immediately after delivery, but don't need to necessarily start right then and there. But as long as it's just before the 21 days, so you don't have to wait after that. The combined hormonal contraception, so it has to be at least 6 weeks after childbirth for women who are breastfeeding, and also consider if they have risk factors for VTE as well. If they don't have any additional VTE risk factors and they're not breastfeeding, technically they could start it 21 days after childbirth. But yes, I'd say most women are going to fall into the category of breastfeeding and may have risk factors for VTE. And then female sterilisation, that's also an option, but I think a lot of sort of consent and discussion discussion surrounding sort of consent to the procedure has to be done prior to the cesarean section. And then lactational amenorrhea, like I said, the woman is less than 6 months postpartum, breastfeeding, that could be an option as well. So this is the guidelines where I took a lot of this information from, and you're going to see that they have guidelines basically for all sorts of contraception categories, and this one was specifically about contraception in the postpartum period. So I'm just going to show you a few more tables which are relevant to this topic. So you can see here that they have different categories of risk. So category 1 is absolutely fine. Category 2, there's, yeah, if you know, generally the benefits will outweigh any of the sort of theoretical proven risks. Category 3 is when you start thinking quite hard about whether the risks outweigh, the benefits outweigh the risks or not. And then 4 is just, you wouldn't use it in the scenario just because the risks would definitely outweigh the benefits. And the reason why this is relevant here, so you can see in the postpartum period, depending on the exact number of weeks and the type of contraception here, you're going to see the different UK MEC, what do you call them? Sorry, categories. Yeah. So you can see here, in 0 to 6 weeks, that combined hormonal contraception is not going to be advised. Interestingly, the depot injections, that's the DMPA, that's obvious, that contains progesterone, but it's still slightly riskier, just because of slight risks of VT with that. But on balance, it's only a 2, so it's not as risky. But I suppose the implant or the pill might be better options in that case. But yeah, so hopefully it's a useful table. Again, feel free to go through it in your own time. And this is also to do with contraception with women in history of pregnancy-related conditions here. But you can see actually doesn't really make too much difference if a woman has had a complicated pregnancy. A lot of these are still options for them, the different types of contraception. So basically to summarize, not summarize, this is a different topic here. So just a little side note, so emergency contraception in the postpartum period. So this is indicated for women who have had unprotected sex 21 days and after childbirth. So levonorgestrel, ulipristal are safe to use 21 days after childbirth. And if not inserted at delivery, the copy intrauterine device can use from 28 days after childbirth. But if you're using ulipristal, just be aware that women who breastfeed they shouldn't breastfeed within the week after they've taken the ulipristal, and the advice to express and discard that milk. So just a few fun facts there. And I think that comes. Oh no, there's a few more bits here. Okay, sorry, this is basically reiterating the point. So what you have to do if the contraception is started 21 days or after, so with the levonorgestrel intrauterine system, 7 days, progesterone only pill 2 days, the progesterone only implant or injectable 7 days, or the combined hormonal contraception would be 7 days as well. So all potential things they could test you on. I know it's a pain to remember all this stuff, so don't worry if you can't remember all of it. But yeah, it could come up, and maybe in an OSCE as well. I suppose it could. So some other areas that I didn't get a chance to cover in this session, but I think could be examinable. I was just having a real think about what actually came up in my exam. So I think knowing the criteria for HIV PrEP and PEP. So who should get treated with that, who should get that, and at what point you can give PEP, for example, post-exposure prophylaxis for HIV. I suppose also another topic that came up was how you monitor HIV treatment as well. So what do you look at to make sure that that is effective? I didn't really go over genital lumps, warts and ulcers, but very important as well to know differentials for those and how to treat those. And syphilis as well could come up as topics, but I think I tried to cover all the main ones that I definitely remember coming up. And just a particular emphasis on just knowing how things look under the slide. It's nice, straightforward marks if you can just look at the slide and know for sure, oh yes, that's gonorrhea, that's chlamydia, that's trichomoniasis, BV, all those differentials I was talking about. Also have a look at cervix findings as well, like we showed. So the tropian, strawberry cervix, they could come up both in your MCQs, or I suppose it could come up in an OSCE as well. If you have that as one of your stations, vaginal or penile examination could come up in those. So yeah, just have a revise of those. And I'll get to Ria's question now, sorry. So if this was an OSCE scenario and you needed to counsel the patient, would it be worth mentioning lactation and amenorrhea, or is it unnecessary if the patient explicitly mentions only breastfeeding and not having periods yet? I think it would be good in an OSCE scenario to just get an idea of what the patient wants first, I suppose, and that will help you narrow down what you want to talk about. I suppose you could always, just say there are various options. Have you had a think? And if they say, oh, I definitely don't want any, I don't want to use any pills, I don't want to use any devices, then I suppose that's one of your only methods, really. But you do have to explain exactly that there are certain conditions for it to be effective, and only really effective up until 6 months as well. So yeah, I would say definitely worth mentioning, but I think always just get an idea of what they want first, and hopefully they'll guide you to what you should be talking about. And yeah, you can get those marks that way. But yeah, very good point. Okay, and just, oh yes, so these are some of the sources where I got my information from. So the FSRH, so that, I think that's a Sexual Health Committee in the UK. They have a lot of really good guidelines on there. That's where I got the contraception guidelines, the UK Met guidelines. So yeah, have a look at those. And then BASH as well is also very good for sexual health condition, resources basically and guidelines. Have a look at that. Teach Pupils and Gynae has a sexual health section, obviously specific for women, conditions that happen in women. But yeah, still very useful. And Geeky Medics as well has quite a good section on sexual health articles and questions. So yeah, have a look at those if you want to do some reading in your own time and follow up on what we talked about today. So yeah, thank you so much for bearing with me. I hope you found it useful. Feel free to find us on social media, and we'll be posting the recordings on various pages that we have, so the website, YouTube, and I haven't actually made a feedback form for this, so I'll try, and what I'll do is I'll send it out as an email. You'll hopefully get a notification about it, and if you've got time, I'd really appreciate some feedback as well. But otherwise, I hope you found that useful, and let me know if you have any questions. I can stick around for a bit, but if not, well done. And yeah, good luck for any upcoming exams. I think we're heading to that season now. And yeah, oh, no problem, Ria. Hope that was useful. Okay, I'm gonna guess there's no more questions. So yeah, I'll end the session there. But yeah, thanks again.